but we might as well just kick off. I have some introductions to do anyway. So today we're going to have a conversation with Dr. Feezor. He's a vascular surgeon here at Halifax Health, a part of the UF Health Heart and Vascular Surgery team. And he's going to talk about surgical carotid revascularization and surveillance. Is that not correct? Something like that, right?
That's right. That's good.
There's a beautiful picture of our Halifax Health Tower. Love that thing. So I wanted to get a moment to make a note to let everyone know that the goal for our support after stroke is to help reinforce discharge information while exposing stroke survivors and their caregivers to current information on how to navigate life after stroke through virtually monthly talks. So we have these monthly talks advertised on our Facebook page. I'm going to try to get more advertisement out so to ensure that we have a better catchment overall. Because I think it's important that we reiterate the education we get in-house so that we can help prevent reoccurring strokes or new strokes from occurring if you come in for to be seen for a transient ischemic attack. All of these pieces are really important on self-care, management of your comorbidities, and it's very important to be an active participant in your furthering of that looking for health in stroke. That being said, I'm going to turn it over to Dr. Feezor. Welcome.
Thank you very much.
So, as far as surgical carotid revascularization and surveillance, it sounds like a mouthful, but essentially, I guess what we wanted to talk to you about is the patients that essentially come in and they get worked up and they find something in their carotids that could indicate stroke. How do we process through that?
Yeah, so, I think that's one of the things that everyone who comes into the hospital with a stroke or a potential stroke at some point will get a carotid study, either an ultrasound, a CAT scan, or an MRI. And when people have found blockages, or when the physicians find blockages, they oftentimes will call me or my partner. And the question is that blockage related to their event that led them to coming to the hospital? And I'll be honest with you, most of the time it's not. Most of the time the carotid blockage does not cause the immediate symptom. But the trick is then what can we offer to help decrease the chance of either another stroke or a first stroke, depending on how the patient presented. And so it's real important when people get a diagnosis of carotid stenosis or narrowing of the artery in the neck that goes to the brain. It's really important to kind of look at the patient in totality. And that's one thing I think vascular surgeons do well, and I know my practice does it well, is you look at the blockage and you kind of it's a chance to talk about the patient. Okay, here are the things that we could do outside of the operating room to decrease the chance of having a stroke. And then on top of that, are there things surgically or with wires and catheters and stents that would also help decrease the chance of a stroke?
Right. And now I have a quick question for you. Like, how soon after an event would you prefer to see these patients for follow-up?
So I guess the question is, if they're in the hospital, it's a multifaceted question. If we think that they, let's say someone comes in for dizziness, right? Because that's very common. And people say, oh, I'm dizzy, mom couldn't stand up or whatever. And so, and then let's say it turns out that mom does have some carotid blockages, but it wasn't the cause of her dizziness. So this is truly an asymptomatic patient. In those folks, we usually see them in about a month. Obviously, like when we see someone in the hospital in sort of acute care setting, even if we're not going to operate on them, we sit down, I mentioned, look at the patient in totality. So we look at their medications. We look at to make sure they're on all the right things that are protective from a cardiac and vascular standpoint, aspirin, give them the smoking lecture if they're still smoking. And then to me, the most important thing, in addition to we set up a date and time to come back to my clinic. I just lost your slides.
Sorry, coming back up.
That's right. But the other thing is we give them a phone number of my practice so that, God forbid, if they were to get home and before they see me in clinic, if they have some event that they're worried about, they've got an immediate phone number they can call and ask for help, or say, okay, this is what's going on. Do I need to be seen right away?
So it's imperative that they get discharged on the proper medications for preserving flow, correct?
Absolutely. In fact, the two medicines that I always tell folks, everybody with carotid plaque or blockages should be on, unless it's a contraindication. Everyone should be on an aspirin at least. It's the world's greatest, cheapest drug. And then a cholesterol pill, one of the statins. Now, there are side effects, and so it's not universal that everyone gets it, but there has to be a really strong reason to not be on those two medicines, because they protect patients against strokes and worsening of their carotid plaques.
Now, would you also recommend, if the patient had hypertension, to maintain their hypertension medication?
Yes, absolutely. That's great. A lot of people get put on different medicines. And so in addition to putting them on a cholesterol pill, in addition to putting them on aspirin, we look over their medications. If they're diabetic, make sure their blood sugar is okay. If they're on blood pressure medicines, make sure it's in a good target range, not too high, not too low. And then things like I mentioned, smoking again. That's one of my biggest sort of mini soapboxes in a very polite way. I'm told smoking cessation is really hard to do. It will never change how I interact with patients, but I never miss an opportunity to encourage people to stop smoking, give them the tools, and sort of just the reassurance that keep at it. If you're smoking, keep trying to quit.
Right. And we should be discharging these patients with some kind of support, like a medication support or a support group to go to for smoking cessation, correct?
Absolutely. There's back when all the tobacco companies got sued, there was a bunch of wonderful resources that were free. Counseling, patches, pills. It doesn't matter to me how they do it. Whatever the trigger is that makes them stop, we just need to make that happen. A lot of times it's sort of just changing something about their life, having your cup of coffee in a different place, or making your significant other go outside the house to smoke or something like that.
Right. So we have a couple of different situations, right? So it's either an acute phase that could have possibly caused the issue, or the shutdown of the blood flow to the brain that could cause damage a stroke, let's say. Or we can have just flow issues, right? That can just present as a TIA component.
Yeah.
Right.
So what, in general, to kind of be specific about it, when we talk about carotid plaques, what we're worried about is a little piece of plaque flicking off. On the screen there are beautiful, at the top, that word emboli basically means a little plaque that flicks off and goes to the brain. That's what we're trying to prevent with carotid disease. And the big question is the patient symptomatic, or are they not symptomatic or asymptomatic? Because the risks of a subsequent stroke are extraordinarily different if you've had a previous one or if you have not had a previous one. And for any surgery, all of us have to balance, okay, what's the risk of doing surgery? What's the risk of doing nothing?
Right. And you were saying follow up in about 3 months?
No, in 1 month. In 1 month. And mostly, honestly, we don't need to re-image the carotid. We don't need to, but it sort of gives a chance. Getting in and out of the hospital, as everyone knows, is a very confusing endeavor. And so it gives a chance to kind of look over all your medicines, to make sure people always have questions, to make sure that they are not symptomatic if they were not symptomatic, and sort of a chance to sort of see people back at their baseline, or at least closer to it.
So once you have all of that ironed out, they come back and they see you. They're on the medications that you recommend. They actually follow up and come to your office, which we find that it's sometimes difficult for that to happen as well, right? Sometimes we don't get those patients that come back to follow up, right?
Yeah, there are ways we can increase our odds, but you're right. I mean, a lot of times people can't, or Halifax is a big hospital. They live too far away and maybe find some local provider, which I understand.
Right. But it's important that they do follow up. So once they do follow up, and let's say that they see you and you say to them that the plaque is large enough, it needs to be addressed. We need to do something for it. What are the options that a patient would have with carotid disease?
That's a great question. So there's 3 options with carotid disease. One is to do nothing. And by do nothing, that includes medicine. So make sure you stay on the statin, make sure you stay on the aspirin, make sure you don't smoke, and then get a surveillance ultrasound in a period of time, usually 6 or 12 months. So option 1 is do nothing. Option 2 is standard carotid darterectomy, which is a surgery and an incision in the neck. where we basically clean out the plaque. And then option 3 is to put a stent in and open up the carotid with a stent. And there's nuances to each, and I think a lot of the times it's determined by the anatomy, what the patient's anatomy looks like, what the patient looks like. For instance, if someone has had a bunch of head and neck radiation or something like that, that makes a surgery riskier than putting a stent in. But in general, there's 3 options: medicine only, darterectomy, which is an incision and actual surgery, and then putting a stent in.
So what kind of risk versus benefit does the surgical component, if you decide that they do need some intervention, right? What would make you choose one over the other, or is it just preference, or is it actually have to do with the clot itself?
It's mostly the patient's anatomy, and what I mean by that is if like where that artery splits, the one on your screen is a perfect example. The one going straight up with the emboli, with the little arrow pointing to it, is the internal carotid artery. Sometimes the split into the internal and external is really high. Well, the carotid kind of goes up, and I'm sort of doing this with our cheese little web. And it goes up and tucks in behind the skull base. Surgically, that's really hard to get to, and so those people you can't fix very easily surgically. So that would be a patient who would be better off with a stent. Alternatively, we get the privilege of taking care of some people who are quite old. If someone is extraordinarily old and debilitated, the stent is probably a little bit more easily tolerated. On the other hand, let's say someone comes in and they're 55 years old and they have a 90% carotid plaque and it's sitting right here. That's a pretty straightforward surgery with good outcomes that we know. And I think darterectomy, which is the name for the surgery, was first described in 1953. So you've got 70-year outcome data that you know. And so in patients who can tolerate surgery to anatomically straightforward, I think surgery is probably still the best, although the stenting is now getting better and better.
That's very interesting to hear. Is there any age range where you would, well, you just kind of explained all that as far as the age range and pieces like that. Is there any particular plaque like that you would choose to do one over the other, or no?
Absolutely. So sometimes the plaque is very calcified. Calcified plaque doesn't do well with stents because the stents are just metal. And if you think about trying to open up a calcific pipe, it's not going to work. And so those people need surgery. We can tell that with the ultrasound and sometimes with CAT scans. And the thing that always worries us is if the entire circumference of the artery is calcified, those people are probably better off with surgery. You touched on the age thing. If there's one thing I've learned from living in Florida now 22 years, boy, it gives you the number. I have patients who are over 90 who I swear could lap me on the treadmill in the track. So age by itself doesn't scare us.
Yeah, that's good. It's good to know. I know that when we're done with all that surgery, they're in the hospital for about how long would you expect downtime for these patients? And is it different between the stenting as opposed to the carotid and darterectomy?
So both carotid stenting takes about 1 hour in the operating room with the patients usually completely asleep. Carotid and darterectomy takes about an hour to an hour and a half. Same thing. Over 90% of people from either stenting or surgery go home the next day. So it's nice. One night overnight, and then I sort of just tell them to take it easy. Usually by about 2 to 3 weeks, they're back to normal. They're feeling fine and doing well. We watch their blood pressure. The key, and I think this is one of the things that distinguishes vascular surgery from other surgical disciplines. Once you have a surgery, we follow you forever. And so let's say you have a carotid endarterectomy, that's sort of the standard old-fashioned surgery with an incision, which still works great. You go home the next day. I see you back in my clinic in about a month with an ultrasound to make sure I did my job, quite frankly, make sure the patient's doing okay. And then if you look perfect then, I'll see you back in a year, and then about every year afterwards for the rest of your life. And we're looking at making sure there's no recurrent narrowing. We're also looking at the other side, and then it goes back to the very beginning. Then we, every time we see you, we say, okay, are you smoking? Are you taking your aspirin? Are you taking your cholesterol pill? And so it's when you kind of start being seen by a vascular surgeon, particularly for carotid disease, especially with an operation, that's a lifelong relationship that we develop.
So aside from that, when they come back too, like if you have plaque in one artery, the risk of having plaque in other arteries is probably pretty good, right?
Yeah, the pipes are the pipes no matter where they go in your house.
Yeah. So like, it's probably good to have a relationship like that with you.
That's exactly right. It's not uncommon that people come in saying, my carotid's doing fine, but I've been having this chest pain, or I've been having leg pain, or something like that. Cardiovascular health is not just about one particular vascular territory. It's not just the neck. It's not just the heart. It's sort of everything. Now, the good news is the medicines that you need for coronary artery disease are the same medicines you need for carotid disease, and so you sort of help minimize the symptoms for all of them.
Which is really good overall health for the patient and getting them on track with following up. So I guess one of the takeaways for this would be the importance of maintaining your personal health and taking ownership of how you take care of you once you know that there's an issue, right?
Absolutely, and that's why things like Halifax does a great job when the whole live your life well theme and the stroke support. It matters. I mean, I recognize that I get the privilege of doing some pretty intense, invasive things, but people get more, if not the same, at least more healthcare benefits by maintaining an active lifestyle. Get out and walk. My kids always fuss at me because I'm the guy that parks at the other end of the parking lot at Publix because it's a few extra steps. I mean, I can tell you how many steps I have done today just to kind of stay active and healthy. And,
right.
We live in Florida. That's an advantage.
It certainly is. Now, this is just a question like off the cuff from me. Have you ever had a patient have a reocclusion?
Yes. So if you do a carotid endarterectomy, you can have people with narrowing above or below where you fixed, or the body can develop scar tissue in the artery. Those people, in fact, about an hour ago, one of the other surgeons here in town is sending a patient over to us for just that reason. And it can happen, and it's a little bit trickier to treat because redo operations are harder, but it's possible. And so that's honestly the reason I get an ultrasound about every year. Now, the farther out you get, the better your chances are. So if 3-4 years out from a carotid endarterectomy to surgery, if you don't have your current narrowing, it at all or pretty small.
So again, follow-up is super important.
Right, and that's one of the things, when we started the vascular service line here, we make a very good point to give business cards with our phone numbers. We make the appointments for you so the patients don't have to do that when they go home. They don't have to call it. It's all written right there, date, time, and from a logistics standpoint, my office building right here, I'm in the hospital, so that helps.
Yeah, it does significantly help. Is there anything else that you want to add before I open it up to questions?
No, I'd say, my plug is that, we always say no matter what we're treating, you always want to make sure the therapy is tailored to the provider. And so the three options, vascular surgery can do medical therapy, we can do surgery, and then we can do the wire catheter stent thing. And so I think we're pretty good at picking the right patient for the right procedure for the right patient.
I would tend to agree with you. So I think you guys do a very, very wonderful job. And I'm going to say, I know that one of the people on our discussion had questions that she wanted to bring up. And I don't know if Beth, if you're listening or not, if you're able to unmute yourself. I know you had specific questions about your mother-in-law as far as surgical options.
Hi, I had just been wondering, my mother-in-law is 85 years old and she doesn't do well under any kind of surgical procedure. She doesn't handle anesthesia well. So you had talked a little bit about doing the endovascular procedure where you went in and removed some of the, like almost like a rotor-rooter thing, I thought you had said, something like that, where you could kind of clean out the plaque endovascularly.
Yeah, it's not quite like that. We don't remove it. What we do is we actually just put a stent in to open it up and sort of trap some of the debris against the wall.
Okay. So for someone like her, it would depend on what you said about the type of plaque and what.
Yeah.
Okay.
Yeah, it sort of depends on the plaque, and I'd say what you said I hear a lot, and this is coming from someone who's never had surgery and doesn't ever want it, but certainly some of the patients that say they don't do well with anesthesia, it's really historically they haven't done well. One of the things, Halifax, we have a tremendous group of anesthesiologists who work here, The team that I get in the operating room, they are used to me. They're used to the patients who are, sounds like your mother, 85, probably multiple medical. I mean, I don't operate on healthy people. It never is risk-free, but the anesthesiologists are the best I've ever seen at getting people to sleep safely and waking them up very atraumatically, if you will.
Okay. Well, thank you.
You're welcome.
I think that was a question that kind of is overarching, like we had talked about, like the choice, the picking of the either medical management, the surgical intervention, or the stenting, and that it would be the question of the day for everyone going through the discussion. I think at this point, if nobody has any other questions, we're going to let Dr. Feezor get back to his surgical rounds.
Right.
Yeah. Well, thank you so much for being with us. We really appreciate you being here and having this discussion with us. And hopefully it'll make somebody be a little more attentive of maybe stopping their smoking habit or following through with going to see the doctor.
That's right. Thank you for the invitation. And if anybody needs anything, reach out to me, okay?
You got it. Thank you so
Thanks,
much.
Thank you.
Bye.
Bye, everybody.
Bye.